58 years old male with alcoholic chronic pancreatitis and epigastric pain since 7 months ago. In last February, CT showed a pancreatic pseudocyst in the tail of 7 centimeters. In this month, MRI, no modification in the size of the pseudocyst, but persistence of epigastric pain. US guided a pancreatic pseudocyst drainage now.
First of all,
Yes,
Michel and
we wanna thank Mark and the organizing committee for this wonderful conference. The case are spectacular. We feel both of us very honored and privileged to be here.
Definitely. Yep.
So this is a very, very nice case, and my partner here is gonna do a fantastic drainage.
We'll see. We'll see. Because this one is not easy, I can tell you that. I'll show you the pancreas if you have the EOS image, and this is the pancreatic body, where we can...
Can you see the EOS image on the screen?
Yes, Michel, we can see it.
Where you have the pancreatic duct here, which basically looks normal, as does the rest of the pancreas. Also when I rotate towards the head of the pancreas, and when I rotate towards the tail, still it's normal, and then we start to see some abnormalities coming. A small cyst, and there's a stone. I think you can appreciate that. Another one. Here's the splenic artery. And then deep from that, which is kind of hard to see because of all the interfacing stones, there is a fluid collection here. As you can see here. But this one is a tricky one. It's far away, as you can see, long distance. And this is what we call a segmental chronic pancreatitis. So his pancreas is basically normal, apart from the tail. And these patients in general are not very good candidates for endoscopic therapy, for transpapillary therapy, because then you would have to pass through a normal gland, normal duct, so stay away from that. In this case, with a cyst, actually this is worth treating, I think, endoscopically, because if you have a little bit of luck, you drain the duct and you solve his complaints. On the other hand, this is a tricky one, so we may make him more ill as well. And we were extensively discussing the pros and cons of using metal for cysts and necrosis drainage, and I'm sure we'll talk about that later on. But in this case, I think we both agree that if anything, you would need plastic for this one. So what I do is I'll try to put in 2 double pigtails. And that's another advantage, I think, of plastic over metal, is that in this case, when he responds well and everything works out well, then you could leave the stents in. You could leave them in indefinitely, or even some people exchange them. We don't usually do that, but that's another option. And I'm happy to do that with plastic, but I would not be happy to do that with metal, to leave that in for a long time, for a very long time. So anyway, I'm wondering who of the faculty there or the audience would proceed to try and do this. Because I'm a little bit doubtful, but Mark told me to go ahead, so I'll do it. But
I think it comes down to indication.
Needle?
I mean, if the patient is symptomatic with the fluid collection, then you have an indication. I mean, if obviously this patient walks in with no pain, you could probably try to, send him for Eswell, break the pancreatic stone in the duct, etc. But I mean, if he has symptoms and there's a fluid collection, I think most people will argue that drainage is the way to go.
Yeah, I agree. But of course, you always have to.
Could you comment a bit on the risk of bleeding? It's nearby the splenic artery. So could you comment
I'm not too worried about that.
With plastic or metal?
Yeah, so that's a very good question. I think the rise of endoscopic ultrasonography to drain pancreatic fluid collection has dramatically decreased the risk of bleeding. But bleeding is still an option. I mean, even though you're using EOS, even though you can see where the vessels are and you can avoid them, when you have a fluid collection that is decompressing, sometimes you can bleed from within the wall of the fluid collection. Now you asked specifically about the difference between metal stent and plastic stent. Well, plastic stent, when they rub against the end of the fluid collection, they will not typically lead to erosion of vessels. Metal stent may do that.
Yeah.
Hence the necessity of using very short metal stents, such as the Lumina Posi metal stents, or what we used to do before placing Lumina Posi metal stents, we used to place a biliary stent and pigtail, double pigtail the biliary stents, so that this will prevent, when the cyst is collapsing, to have erosion of the wall of the fluid collection by the metal stents.
As you can see, it's quite hard to find a good window, especially with the needle in, of course. It's a little bit harder to bend the scope with the needle in. I may be able to get here now, but not very attractive.
Can we dim the lights? Can we dim
That's a little bit light in here. So
What do you think
ideally,
about the aspect of the content? Do you think it's really a pseudocyst or is more?
This is not a clear.
I think it's a pseudocyst,
it
but
must be a pseudocyst, yeah.
But it's probably a chronic pseudocyst because
Yeah.
you can see the wall very nicely here. And then it's almost connecting with the duct over there where the pancreatic stone is.
Yep, here.
So I think it's one of those, chronic pseudocysts. And I think at
I may go
some point
below,
we need to
actually.
fix the duct at some point.
Well, not
And it's
necessarily.
clearly symptomatic.
Yeah, he's symptomatic. I mean,
Yes.
if he wouldn't be symptomatic, I wouldn't even think about starting treating this. There's also something inside here, which we saw on the MRI as well. I think actually going below the splenic artery is better than going above. So I think this is I'll turn this off because, like Michel, it only gets me nervous.
It makes very nervous people when you have the Doppler flowing back. Makes me so nervous.
So this should be okay. Okay, now I'm
Alright.
in.
So we can see how nicely we're able to avoid, that vessel. That's very, very important. I'm gonna
Take out the stylet and then I'll use a little bit of contrast.
So here you can do a different thing. You can inject contrast or you can take a sample. What do you want to start with?
Well, we can take a sample
Okay, should
for
we take a sample?
diagnostics.
Okay, we're gonna take a sample for
Yeah,
diagnosis,
section.
and then we're gonna get some contrast.
If we can
inside.
get anything. Yeah. So it's yellowish
All right.
fluid, it's not really pussy. That should be enough. And then I inject some contrast. And
Okay.
I do that for several reasons. One, especially in small ones like this, it's actually better to have it fill up a little bit. Oh yeah, if you want to
Beautiful.
inject, please.
Okay.
Can we have fluoro, please?
X-ray, please.
X-ray?
X-ray.
Scopy? Oh, okay.
If we can center
And
the
we have,
X-ray, that
and we
would
have
be-
here in the audience the X-ray imaging, please.
Yes, we're gonna show you that
Okay,
in 1
thank you.
second. As soon as we center it, because right now we're looking at the pelvis.
Okay, you can see it fill up. So one is
Yeah.
to fill it up a little bit. The other one is to
bigger.
get a feel for the size and the anatomy.
You want
Just
water
a little
now?
bit more.
You want to dilute it or you want contrast more?
No, just some contrast.
Contrast
sorry,
more,
yeah.
some more contrast.
And sometimes also you see the duct.
So at this stage, you basically committed. Once you have injected contrast into a fluid collection, you basically committed. At this stage, you have to drain this patient.
Okay, I think that's it. That's enough.
No turning back.
No pressure. No, no, no.
So what's the maximum
It's okay.
distance you will drain a cyst from the wall?
Yeah, I think this is about the maximum, really. You know, it's also depending very much on the setting. The most, actually, the majority of fluid collections right now we are draining are those patients with infected necrosis, and then it really doesn't matter all that much. It can be just go on. Can be 2 or 3 centimeters. Yeah,
Yes.
let it curl up nicely.
So you see, it's very important to have a multiple coil.
Yeah,
The
go
more
on.
coil you have, the more stable you are,
Can you push
the
on?
more safe the procedure is. It's very important to take that extra time to get a nice coil because
Yeah, this should
this
be
will
enough,
increase your stability.
Okay, so now we do the
to the procedure
exchange.
here. So very important to sync
First, I take
with
the
the
needle out.
endoscopist.
Okay, then we do the exchange.
Okay. So you have to really adjust to the speed of the endoscopist.
Keep watching, please, fluoro.
Very, very important to get that wire access. And as you can
Yes,
see here,
I'm done.
we are maintaining not only the fluoroscopic vision,
But also EUS.
but also by EUS. And
That's very
in the
important.
center of the image, you have the wire, because this is the direction of your drainage.
Now, what I normally do right now is I would use a balloon and try to dilate and then put in a second wire with
Yeah.
the Fusion Oasis 8.5, but we don't have that available.
So you have
So I'm
something
using
better.
the cystotome
You have the
now.
cystotome.
Yeah, which I'm not necessarily convinced it's better. But the one good thing about the cystotome is that it's very
What's wrong
easy to
with the
get in the
cystotome?
second. Well, there are several things
What
wrong.
kind of cystotome?
This is
Ah.
the 10 French cystotome made
Yes.
by Cook, which is, and only the,
This is
no,
the
I want the big one.
This is the only cystotome available in the United States.
And oh, yeah, you
The
have
6
to-
French cystotome is not available yet because of FDA. And in this case, I think I would recommend a cystotome because the wall of the fluid collection is pretty thick.
Yeah, it will be very
There's a
hard to
big
pass
distance,
this
so I
with just
think
a
in this
balloon.
case, a cystotome will be the way to go. But I agree that there are cases when you have a very small fluid collection adjacent to the stomach, you can go straight with the balloon. I totally agree. But this case,
Oh, and also, especially in affected necrosis,
Yes.
you really don't need the cystotome. And we do have a feeling, this is not evidence, but just
Correct.
a mere feeling, that there's a greater chance of bleeding when using the cystotome. But
so
once
this
again,
is a very
this is not,
important step of the procedure where the endoscopist is going to push the cystotome and I'm going to give him some tension.
just wait a minute, Michel.
Just so, yeah, whenever you're ready, of course.
Yeah, I'm trying to get the pedal.
So you use a pure cut?
Typically, I would use endocut.
This is the great question. There's so much resistance to go through the wall that it doesn't matter. You're creating so much resistance that you are coagulating even if you use pure cut.
Yeah, probably. Can
I'm
I
going
have
to give you
Scopy?
some tension whenever you want.
Okay.
And how much power are you using?
Well, that's actually what typically we do. You
I
have to
just
be
use-
at least around 60 watt, at least. Some people will go all the way to 80. But the 60 with effect 1 should be okay.
It doesn't really matter what number you put in there because the machine will adjust it automatically. So we
It
can,
depends on your unit, though.
yeah, that's true. You can see the cystotome in the EUS image on fluoro, not so well, but I think we'll see it appearing.
Okay?
Okay, so now I'm starting to cut.
So I'm going to give gentle tension.
Think I'm in. Yeah,
That's
now
it.
I'm in. Now I'm
See,
in.
tension is very important here. So what I'm going to do at this point, I'm going to push wire while he's withdrawing the cystotome. I know you
Yes,
want to advance
I'm in.
some more.
No, I'm
Okay?
good. I'm good. I'm good.
Okay. So you tell me when you want to get out.
Yeah, now I'm going to put in the second wire.
Okay, you want to put the second wire.
Yeah,
okay.
I want to put in 2
So
pigtails.
this is the two wire technique. The advantage with the 10 French cystotome is that you can actually double your access with 2
Yeah.
wire.
Stop.
So the next step will be just stand. Okay. We can remove the current now.
I
again.
strongly believe in multiple stents. I much rather have 2 7 French than 1 10.
Okay.
Also
X-ray,
to
please.
get in again. Yes, fluoroscopy. Okay, you're
Okay.
not there yet, I think. Okay, go on. Okay, now comes the
Okay.
difficult part.
Okay, the double exchange.
I actually have 2 assistants. There's Florence and
Fantastic.
Michel.
Here,
I
have the,
prefer Florence, but don't take it
I know.
personally.
You know what?
Michel.
I do
It's,
prefer Florence myself. So
Okay, so now we do
go.
the exchange. Scopy, please. Yep. Keep it in there. The smaller the cysts, the fluid collections are, the more difficult it is usually. Unless they become very big, because then you tend to go scuba diving and work underwater. So far, so good. So now I'm here, yeah, I'm in. Stop fluoro.
No, I'm just saying that the important thing is really to not
Balloon?
look endoscopic.
No, this is key, this is key.
No
Just,
balloon?
do you want a balloon?
Yes, 8
Balloon.
millimeter.
8 millimeters.
8
So it's
millimeter.
actually key that you can turn the
Okay.
monitor off, basically, and
it
just
is.
orient yourself on the EOS and on the fluoro image. Then you stay in the right axis. And as you can see on the EOS image, we can still see the guide wire, so we're doing okay. We dilated up to 8 millimeters, which went remarkably easy. And now we're ready to place the first double pigtail, still initially on EUS and fluoro image. Scopie, please. Okay, some traction on the guide wire, please. Some tension on the wire. And there you can see the first stent.
What kind of pigtail you have chosen?
I'm using 7 French stop fluoro, 7 French 7 centimeter double pigtail. You need to use 7 because you have 2 guide wires plus the stent. So with 8.5 it just works, or it just doesn't work, and it's a lot more difficult. I think the effect of the
But the length is
drainage...
7 centimeters?
Yeah, 7 centimeters.
But we're going to place 2, so that'll make
So we'll
14
place 2.
French.
I don't think, some people have all kinds of theories about the length of stents. I think it's completely irrelevant as long as you have access. And the reason to place multiple stents is, of course, that it enables you to get back in again if necessary. And in this case, this may very well be necessary because there were some solid components in there. And then with one stent, it's virtually impossible, unless, of course, it's a metal stent. But with a plastic stent, it's virtually impossible if you use double pigtail stents. And with 2 or 3, you always get back in again. So the stent is now in the tip of the stent is in the fluid collection, and now I'm pushing in until I see the marker created by Florence and Stéphane. So now we're okay. You think you could appreciate that. And now we pull back the guide wire and let the first pigtail form. Scopie. So you pull back, Florence, until we see. Yeah, pull back, pull back, pull back, pull back, pull back, pull back, pull back. I think that's it. Okay, stop. That's enough. And this gives you some, gives you a little bit of stability. Here's a second marker. We were digging around a little bit. And now with pigtails, it's always a little bit difficult because you need to deploy them without pushing the pigtail in the fluid collection, of course. But this is okay. Okay, pull back. Everything out. Okay, that's one.
X-ray?
X-ray, fluoro.
Oh, beautiful.
That's it. And now we put in the second stent, and because we dilated, that should be easy as well.
I think the debate on the size of the stent is not very important.
No.
In fact, what is important is the size of the cystogastrostomy. Like we have here a good size, and also the number of stents. And I think 2 stents is better than 1. Even if it's 2.7 or 2.8 or 2.10, I think there is no big difference. The role of the stent is to maintain open the cystogastrostomy.
The lumen is irrelevant, really. Okay, so there's number 2.
During dilatation, was there any emptying of the fluid?
Oh, yeah.
The size of the lesion,
Definitely.
Has it Definitely.
Definitely,
Okay.
and you can see this is typical chronic pancreatitis. If you look at the endoscopic image, that first we have to get this one in.
Be careful.
Little bit of traction, Michel.
Le guide.
Ça va donner un peu plus de guide là.
Yeah, put the guide further.
I'm gonna give him more wires to give him more tension. Okay. Now I can give him more tension.
Oui.
But I'm bending, can you see?
Il faut le faire.
Yeah.
So I have to change my position. This is the problem, of course, with double
La
pigtails.
deuxième, elle est naze.
Tension on the wire.
The second stent is...
So despite the dilation, I think we're still stuck on the wall. And you can see where we're going, not the right way. This is highly annoying.
La deuxième, elle est naze. Ah, yes.
Okay.
Yes.
No. Trying to get as close as possible.
I think the solid stuff inside the cyst is
Yeah,
causing
I
you
think that's the problem. That there's some solid stuff
No, if there is no
that's preventing.
Tension on the wire.
And you go
Yes,
to see
yes,
the
yes,
also
advancing.
the
Yes, now I'm in.
Yes.
yeah.
I think.
Yes, you are. You are definitely in.
Yeah, I'm definitely in. Okay. And this is the nice thing about these drainage procedures. It's always it can stay difficult until the very end. But I think this patient is at risk for leakage. This is without infection, without real inflammation. Okay, can you pull back the guide a little bit, Michel?
Mm-hmm.
Yeah, there's the pigtail. Okay.
Okay.
Okay, so now we can do the second one. There it is.
Done.
But if you look at it, this was
Beautiful.
the point.